chair the third topic, I am pleased to welcome Dr. Panneer Selvam. Dr. Panneer Selvam, consultant diabetologist from Aruna Diabetes Center, Chennai. Dr. Panneer Selvam has actively participated in various national forums. He has got to his credit some few publications. I welcome Dr. Panneer Selvam to the dais to do the proceedings.
Good evening to all of you. After listening to the two topics, the mechanism of action of gliptin and where we have to position the gliptin after metformin, now we are entering into the third topic, the treatment of type 2 diabetes from an endocrinologist, cardiologist and nephrologist point of view, a special approach. Of course, as we all know, all diabetes at one particular point of time they develop some complications, or we deal the case with some comorbidities. The common complication, as we all know, nephrological aspect, diabetic nephropathy and our diabetic cardiomyopathy also. After entering into the complications, how we are going to handle the patients, the various molecules. To talk on the subject, as we all know, he is our national speaker, internationally known, Dr. Shan Joshi. Last week also he was here in Chennai. He acquired MD General Medicine, DM, FACP USA, FAC USA, FRCP Glasgow. Dr. Joshi has been awarded the Best Clinician of the Year 2012 by the American Association of Clinical Endocrinology. He recently honored with Padma Shri, renowned speaker and moderator. He visited Chennai many times. All of us are very friendly to him, and he is a well-known speaker of India. So I welcome to the podium, sir.
Thank you, Dr. Panneer Selvam, for your kind words of introduction. This year, having the mantle of API, I have a simple theme of listening, and I'm sure you have listened to very elegant talks from Rajiv and Avdesh. Then you need to learn something from that, but what will you adapt? And as Osler said, medicine is an ever-changing science with a lot of uncertainty, with art of probability. What I have to do in the next maybe 20-25 minutes is tell you the treatment of type 2 diabetes from different specialist views, how an endocrinologist will look at treating type 2 diabetes. And you will see a lot of overlap between my slides as well as Rajiv's slides in that. Lot of hot topics have been debated in cardiology today. Concerns as well as good things about DPP-4 inhibitors and treatment of type 2 diabetes and the CV outcomes. And we've seen stories of rosiglitazone, etc. through the CV route. Then of course the kidney. So when we look at a specialist approach, let us look at how an endocrinologist looks at diabetes. As endocrinologists, we want to look at pathophysiology. And my good friend Krishna always likes to talk a lot on pathophysiology. We need to look at drugs which not only achieve a treatment target, but with no hypoglycemia, weight neutrality or weight loss. They have a very good safety valve. That means they have no or manageable risk profile. They should be easy to combine with other drugs. It should be easy to comply for patients. They must have beneficial effects not only just on beta cells, but also on the liver. Because we are recognizing that in insulin resistance, fatty liver and NASH and non-alcoholic fatty liver disease is coming up as a very big thing. We also are looking at it as an adjunct in other forms of diabetes, like LADA, type 1 diabetes, MODI, and maybe even other endocrine disorders. So we have moved a lot from simple dual defect of beta cell dysfunction and insulin resistance to a glucose output from the liver, which was a triumvirate as DiFranco described it, to an octet and maybe even to a dirty dozen or dirty 13. We definitely still have unmet needs. We need good drugs which have consistent long-term efficacy. We need drugs which are less likely to induce hypoglycemia. We need drugs which have a lot of weight loss efficacy. We need drugs which will reduce risk of CV events. And we also need better methods to assess drugs' disease modification potential. Can they modify the disease process? Can they alter the natural history of the disease? And we also need drugs which can actually have an impact on complications. So obviously, we need to have that unmet need. so that we can actually change natural history of diabetes so that the disease does not progress and we can manage cardiovascular and other complications. The ADASD statement of 2012, Rajiv very nicely told us, and has multiple pathways, and we have to look at one goal: to avoid hypoglycemia. And after metformin, we have three options: glitazones, DPP-4 inhibitors, and GLP-1 agents. Glitazones have their own safety valves and challenges, and the GLP-1 agents have their own safety valves and injections. So gliptins are right there in the center. When we look at goal of weight gain and avoidance of weight gain, obviously the glitazones go out and the gliptins as well as the GLP-1 agents stay there. And when we look at other considerations, and we are in east of the world, someone says that we are in diabetes east, we have more beta cell dysfunction. So we need drugs which can address that also. Rajiv also alluded to the ACE algorithm of 2013. The current trend is healthy patients without concurrent illness, low hypoglycemia risk, hit hard, hit early. Try to keep your A1C below 6.5%. And if you have concurrent illnesses, lot of hypoglycemia risk, you individualize the goal of the patient from 6.5 to 7, 7.5 also. So if you look at the ACE algorithm, at entry, apart from lifestyle modification and medically assisted weight loss, you can use metformin, GLP-1, a gliptin, and a glucosidase inhibitor. Of course, you can also use an SGLT2, which will be soon launched in another couple of months in India, a glitazone, or a secretagogue. And if the A1C does not come down below 6.5 in 3 months, you can go to dual therapy. If the entry level is more than 7.5% but less than 9%, you can go to dual or triple therapy. And if it is more than 9 and you are symptomatic, you need to treat glucotoxicity and give insulin. However, if it is asymptomatic, you can still do dual or triple therapy and or add insulin. This graph also was shown by Rajiv very nicely, that each agents have their pros and cons, whether it is hypoglycemia, weight, renal, genitourinary side effects, GI side effects, cardiac failure, CV risks, and bone. So let's look at metformin. It's neutral for hypoglycemia. It may promote weight loss, but it doesn't meet the US FDA criteria for 5% for weight loss. It has challenges with renal and genitourinary and has GI side effects. With ADOPT data, you could say that it's CHF neutral or maybe a little adverse. It has CV benefits, probably, with 30 years of UK PDS data, and it's neutral for the bone. Gliptins are clearly neutral all throughout, except that in renal diseases, except LINA, you might need a little renal dose adjustment. GLP-1 agents, attractive because they have weight loss, but they have some contraindications, they have some challenges, and they have some GI side effects. Glitazones, great drugs, but their rate limiting step is weight gain, fluid retention, heart failure, macular edema, unusual bone loss and fractures, CHF, and CV benefits unknown. Proactive did show some beneficial data and some questionable concern on bladder cancer in a cumulative dose. Glucosidase inhibitors, very much there apart from GI side effects, but not as strong. I will not talk about Covalcilam because it's not available. Quick release bromocriptine is available in India, but it's really not been extremely popular. Of course, it had GI side effects. It is probably the only agent which got approval by the US FDA after the rosiglitazone CV story and has CV outcome data to it. Then of course you have secretagogues, very much still there, but they have hypoglycemia, mild, moderate, severe. They have weight gain. They are less durable, as Rajiv said. They have more hypoglycemia risk. The CV safety keeps on getting questioned recurrently, but they are neutral on the bone and heart. Insulin, of course, is very much there, SGLT2 and pramlintide. So obviously when we look at the algorithm, we need individualized targets. Medical therapy is not a failure of lifestyle modification, but an adjunct to lifestyle modification. We need individualized therapy looking at risk of hypo, weight gain, ease of use, cost and safety, which Rajiv was alluding to, and of course an effect on kidney, heart and liver, and have complementary mechanism of actions, and safety and efficacy are the highest priorities. So if you look at all anti-diabetic drugs with A1C reduction, weight gain and risk of hypoglycemia, you can see here the A1C reduction may be similar, but when it comes down to weight gain and risk of hypoglycemia, the secretagogues, the glitazones, the AGIs, you can see the relative risk of hypoglycemia is very different. And when you look at weight change, again the glitazones and secretagogues go out there. So obviously, the clinical composite when you are looking at a drug, we want three things: weight neutrality or weight loss, we want definitely no hypoglycemia, and we definitely want a good robust A1C reduction, and probably the gliptins are very much there, and they have clearly been there. You can see a single dose of sitagliptin, and Avdesh very nicely told, has a twofold increase in active GLP-1 and GIP. There's a 22% better output in a glucose-dependent fashion of insulin on the beta cells. There is a alpha switch off of a 12% reduction of glucagon by sitagliptin, and there is a 26% reduction of area under the curve of plasma glucose. That's exactly what a single tablet of sitagliptin will do if we give it in a physiological state. And that is the evidence-based confirmation. So efficacy to efficacy in monotherapy, A1C has a robust drop. After metformin, robust drop. SU plus metformin is a third agent, robust drop. After pioglitazone, robust drop. With insulin, with metformin, again a robust drop. So clear-cut efficacy data. Can it improve markers of beta cell function? Of course. Favorable pro-insulin to insulin ratio, better HOMA beta models. Rajiv showed us this slide. Better insulin secretory capacity, decrease insulin resistance, decrease ER stress of the beta cell and immature insulin. Let me move to the next point. We are seeing with diabetes a clear twofold risk of chronic non-alcoholic liver disease, and we have seen that very, very aggressively. You can see here data published from east of India or from west of India, and you can very, very clearly see that histological nephrology, steatohepatitis and fibrosis with diabetes is as high as 87%, 62% and 37% in Indian population. This was a study done at KM Hospital. I was one of the authors of that study, and Prashant Mappa did this as a DM thesis, and he presented at the Endocrine Society meeting in Boston a couple of years back. If we look at hepatic insufficiency and common oral anti-diabetic drugs, metformin is a hepatoselective drug, and we do not have pharmacokinetic studies conducted in patients with hepatic insufficiency. So we have a caveat with that. Glimepiride, again we don't have studies performed in hepatic insufficiency, and therefore we need to be very conservative with that drug. Glipizide has data to show that there is prolonged hypoglycemia after hepatic impairment. Gliclazide, again precaution with hepatic impairment, and is contraindicated in severe hepatic impairment. With acarbose or AGIs, we are clearly knowing that the transaminitis occurs, and they have suggested a rate limiting step. With pioglitazone, there is no dose adjustment needed for hepatic impairment, but they said that if there are post-marketing reports of liver failure with pioglitazone, and you need to be careful if the enzymes go 2.5 above. What about the European recommendations for gliptins with hepatic impairment? For SITA, no dose adjustment is required for mild to moderate hepatic impairment, but in severe hepatic impairment, it has not been studied. With LINA, they say there is no dose adjustment requirement, but clinical experience is lacking. Similar data is available with Saxa, and vildagliptin did not get US FDA approval because of the hepatotoxicity which was observed with the 100 milligram dose. So what is the effect of these incretins or gliptins on gastrointestinal and hepatobiliary system? Appetite suppression, delaying gastric emptying causing better prandial satiety, weight reduction as a cumulative effect of central appetite suppression as well as modulation of peripheral taste and gastric slowing, better beta cell health, suppression of glucagon, so better alpha cell dysfunction, and GLP-1 is hepatoprotective for hepatosteatosis. So if you look at anti-diabetic agents and gliptins or GLP-1 for NASH or NFALD, due to prolonged GLP-1 receptor activation, there is weight reduction, there is improvement of hepatic insulin sensitivity, there is data to show that the hepatic fatty acid oxidation is improved, and there is also data to show that the hepatic fibrosis is inhibited by inhibition of fibroblast growth factor 21. So this is the mechanistic view that the gliptins may have a very attractive role, particularly sitagliptin has data on it, on weight, liver insulin sensitivity, liver fatty acid oxidation, and inhibition of fibroblast growth factor 21, and improvement of NFALD and NASH. So when we look at data with sitagliptin in hepatic impairment, diabetes with NFALD, there is a very nice study, 48 weeks, fasting and A1C improved with sitagliptin, no change in the enzymes. Diabetes complicated by hepatitis C, again data on sitagliptin, no change in the enzymes, and excellent A1C and fasting reduction. Treating diabetes with NFALD, 16-week data showing A1C drop, glucose drop, and gamma GT or ALT AST has been untouched. Looking at effect on insulin resistance and steatosis, there is a case report to show that even on histology, the severity of hepatic steatosis has improved with sitagliptin. And diabetes complicated by NASH, again with liver scores, decrease ballooning and NASH scores, decrease in the steatosis score in a 3-month trial and with sitagliptin. Let's move from liver to other types of diabetes from the endocrine standpoint. You can see here data published in JCNM recently where they use sitagliptin in patients with LADA, type 1.5 diabetes, where they have shown it maintains beta cell dysfunction and it has an impact on recent diabetes. We have data from 2 studies now in type 1 diabetes with sitagliptin. First was the study which came from Satish Garg, and second is the Elias study. Both the studies have shown that in type 1 diabetes, there is a lot of overactivity of the alpha cells. And it is important to control that excess glucagon and improve the brittleness of type 1 diabetes. And there is now data to suggest that it could be an adjuvant in type 1 diabetes. And this you can see here, better glucose control, lower insulin dose in type 1 diabetes. Another second peak of type 2 diabetes which is occurring is adolescent type 2 diabetes. And in adolescent type 2 diabetes, you can see here very, very clearly good data from sitagliptin, where there is data to show that it can be used in this population. And you can see here the ratio of active to total GLP-1 over time is better. There is very good data also on sitagliptin that in postmenopausal diabetic women, it positively regulates the bone metabolism, the osteocalcin, the bone mineral density, the urinary telopeptides are positively impacted. And probably there is a bone protective mechanism with the gliptin. So from the endocrine standpoint, whether it is the liver, whether it is the pancreas, whether it is LADA, whether it is type 1, or whether it is looking at the bones, this were the perspective from an endocrine standpoint. However, the biggest skeptics of anti-diabetic drugs are our cardiology colleagues. They have put, cardiologists have interfered with diabetes to the extent that endocrinologists have de-recognized the term called metabolic syndrome, because they found cardiologists, because of the excessive use of statins in the US and Europe, have started interfering with endocrine and diabetes practice. Cardiologists have always been skeptical of anti-diabetic drugs. It started from the tolbutamide story. Then of course you had the typical 10-year follow-up with intensive glucose in type 2 diabetes with UKPDS. But one thing came out after 30 years of UKPDS. Ruri Halban, who continued the legacy of Bob Turner, clearly showed that hit hard, hit early, because if you hit hard, hit early in the first decade of a diabetic's life, you will generate legacy effect, you will generate metabolic memory, and you will be able to control your patients better. If you look at across board all agencies now, whether it's American Diabetic Association, American Heart Association, American College of Cardiology, They feel A1C less than 7% in newly diagnosed patients is likely to have benefit with long-standing diabetes and CVD. Benefits may not be completely proven. However, very tight control below 7% is best for people with short duration of the disease, long life expectancy, and no cardiovascular disease. That's the caveat. There has been concerns from secretagogues. For example, this was a retrospective cohort. We have challenges with retrospective cohorts where they showed SUs might increase CVD risk and mortality from a UK-based research database of this thing. We all know the CV risk profile which Steve Nissen bought out from the GSK database, and we know that there is a full U-turn now. US FDA has now said that probably rosiglitazone is a CV safe agent. So obviously they did see some signal. The record is full of its own controversies. So obviously the GLP-1 has different targets. They may be neuroprotective. This data, and Dan Drucker this year in the Banting oration showed us data of GLP-2 in neuroprotection even in Alzheimer's disease. We have data on cardioprotection, but it could also be a challenge with heart failure, and let us look at some of that data. We know that GLP-1 receptors are expressed on cardiomyocytes, endocardium, microvascular endothelium, and coronary muscle cells. There is mechanistic data to show that CV risk modulation might be positively impacted, because there is a study going on that the myocardial infarct size may be decreased, endothelial function may be improved, inflammation oxidative stress may be decreased, atherosclerotic plaque volume may be reduced, LVEF may be improved, triglycerides and blood pressure can come down with the gliptin. So obviously why does that occur? Because DPP-4 substrates directly or indirectly regulate cardiovascular functions. What are the DPP-4 substrates? Let us look at 4 of them. BNP, brain natriuretic peptide, substance P, neuropeptide Y, and peptide YY. What is BNP? BNP is secreted by the ventricles in response to excessive stretching of the cardiomyocytes. It leads to decrease in blood volume, thus lowering systemic blood pressure and afterloads, and yields to an increased output of cardiac output. So what happens to BNP? Substance P, it is released from terminals of specific sensory nerves associated with inflammation process and pain, but has a potent vasodilator and a nitric oxide release effect, which is the positive thing. Neuropeptide Y, it's a neurotransmitter of the brain and autonomic nervous system, increases and modulates food intake, energy fat store, anxiety and stress, pain perception, circadian rhythm, and blood pressure. Peptide YY is often called as the ileal brake because ileum and colon secretes it as a response to feeding. It inhibits gastric motility, increases water electrolyte absorption in the colon, suppresses pancreatic secretion, and most importantly, blunts of appetite. Here is data to show that sitagliptin improves myocardial response to dobutamine stress in patients with documented coronary artery disease. There was a significant increase in ejection fraction, enhanced So I think Avdesh and me are following. I think the computer is tired of us, and improved contractile velocity in ischemic segments. Sitagliptin in a dose-dependent fashion also reduces the carotid intima medial thickness after a balloon injury in animal models. You can see here it has a protective property against restenosis after a carotid injury, and in large vessels it could have a challenge. Post-coronary syndromes in Israel, they analyzed the ACES 2010 data, and they clearly showed with MACE data that sitagliptin was cardioprotective. Avdesh alluded to this point that the reduced CD26 expression is associated with improved cardiac function after myocardial infarction, and therefore if you, there is a sitagramy trial which is ongoing, that if you treat patients shortly post MI with sitagliptin to inhibit CD26, it will increase the mononuclear cell homing to the infarct area, and it will probably enhance cardiac recovery and repair, and this is published data. If you look at the odds ratio of cardiovascular safety, currently the odds ratio is around, from indirect data, the MACE data, the CV safety data submitted to the FDA is 0.67 and 0.68, which is favorable. Other gliptins also appear to be favorable. There is no CV signal which is observed. However, we have 2 trials on CV outcomes on gliptins published. The data was reassuring and disappointing both. Saver-Timmy 53, published by Eugene Braunwald and their group from the Mass General Harvard group and Beth Israel group, clearly showed that saxagliptin was CV neutral but did not meet the primary efficacy objective. However, there was a concern. What was the concern from the Saver-Timmy data? That there was an increase of hospitalizations from heart failure with a hazard ratio of 1.27. The good thing was the pancreatic safety was, there was no increase in incidence of pancreatitis, but the CV hazard ratio was right at 1. The other trial which was there, simultaneously completed in 2013, was the examine trial for allogliptin. Again, the hazard ratio was 0.96. So both show CV neutrality. However, no increase in pancreatitis with examine and allogliptin, but again increased hospitalization of heart failure. The ongoing TCOS trial with sitagliptin will end in December 2014. It has a different cohort of patients completely, much larger size, much larger number of patient years, and we will have to await the results of TCOS to finally have the verdict of this. There is Carolina trial which is also observed, and Vivid trial of vildagliptin is already published. So this was the Saver-Timmy and examine data which showed neutrality, and that is where the cardiac story rests. Let us look at now the nephrologist view. We know CKD and type 2 diabetes go hand in hand. We know there is a lot of end-stage renal disease, and hypoglycemia is huge in CKD because we all know the various mechanisms. And in CKD, the optimum A1C is a challenge. Why with patients with CKD have an increased risk of hypoglycemia? Because we all know that there is decreased renal glucose production. We also know that in CKD there is reduced gluconeogenesis in the liver with decreased mitochondrial ATP to ADP ratio. We also know in CKD the glycogen reserve of the body is depleted. We also know that in CKD there is a reduced or a blunted systemic response to adrenaline and glucagon. But the major factor which causes hypoglycemia is the insulin clearance of various hypoglycemic agents, oral or injectable, and their metabolites is reduced, and there is a decreased insulin degradation. So due to all these factors, hypoglycemia is a big challenge in CKD patients. There is another fallacy which we must observe with CKD patients as clinicians, the fallacy in A1C. In CKD, A1C is highly unreliable. Why? Because you could get a falsely elevated A1C, because we all know that with CKD there is carbamylation of erythrocytes. So you could get a very high A1C. You could also, on the opposite side, get a falsely decreased A1C, because we know if somebody is taking iron or using erythropoietin with CKD, the A1C is likely to be falsely depleted or low. Also due to increased erythrocyte turnover in CKD, because in CKD body is trying to have better erythrocyte turnover, you will get falsely decreased A1C. So remember, A1C is very unreliable in CKD patients, and therefore you need not rely on them. What about metformin in CKD? Traditionally, metformin was always contraindicated in CKD, but there has been a little change. We need to look at CKD and look at EGFR. When we look at EGFR more than 60, no renal contraindication for metformin, monitor renal function annually except age 80 and above. Above 80 years of age, you have a clear relative contraindication for metformin. Between 60 and 45, you can use metformin, and there is a change there, and probably you need better renal function monitoring. Between 45 and 30, you need to use metformin with caution, use it with half maximal dose, more closer monitoring of renal function, and do not start new patients on metformin, and below 30, don't use it. However, there is an additional caution. If there is acute kidney injury or a huge fluctuation in renal status or electrolyte disturbances, avoid metformin completely. What about sulfonylureas in CKD? We need to know clinically relevant pharmacokinetics of glipizide, gliclazide, glimepiride. Their half-lives, their active metabolites, their bioavailability, their molecular weights, and their excretion potentials. If you look at all the three agents very actively, we need to be very careful in using secretagogues or glycides. Among all of them, we know that the active metabolite of glimepiride is probably going to stay longer with renal disease. Gliclazide also has a more propensity for hypoglycemia. Glipizide and ripaglinide might be the preferred agents in this class if one has to use them in CKD. What about glitazones? No glucose adjustment has been required. There is no hypoglycemia. However, the chances with sodium and water retention and heart failure are higher if there is glitazones with CKD, and dialysis data is not there with glitazones. Therefore, there is a caution recommended that if you want to use pioglitazone below eGFR of 60, it is preferable to avoid it. So now let us look at OADs and CKD. Glipizide, no dose adjustment. Glimepiride, use the lowest possible dose. Gliclazide, no dose adjustment. Alpha glucosidase inhibitors, people have a myth that you can use them in high creatinine. Above 2, you should be cautious. Prescribing information clearly tells us that you need to use it with caution. Ripaglinide, no dose adjustment, avoid netaglinide. What about gliptins? We all know that all the gliptins can be used. Only you need to do dose modulation with sitagliptin, vildagliptin and saxagliptin, and linagliptin is not excreted. So if you look at what can you use in CKD, there is a very nice graph which has been given as a clinical practice guideline with patients with diabetes and CKD, and Canadian guidelines have shown very nicely how to use these agents. There is data to show, robust data to show that 25 and 50 milligrams of sitagliptin can be used in moderate to severe CKD. Sitagliptin is the only gliptin which has data in dialysis, head-to-head avoiding hypoglycemia, and ESRD on dialysis, there is a lower incidence of symptomatic and severe hypoglycemia. But there is something more which has come up with the gliptin story now. Sitagliptin showed in a very elegant study on renal ischemic reperfusion that it decreased apoptosis and protected against renal ischemic reperfusion damage. You can see here diabetic kidney tissue, diabetic with ischemic reperfusion, and with sitagliptin clearing it out. There is another new diabetes which has come up. We are seeing more and more patients after transplantation. So the whole new entity of new onset diabetes after transplantation called as NODAT, there is data with sitagliptin to show that you can clearly use it in patients with NODAT, new onset diabetes after transplantation. You can see here there is data available, published, and very clearly it does not cause weight gain and it has very robust A1C and fasting impact. There is good data to show, I am almost done, to show that sitagliptin reduces albuminuria without lowering eGFR. So summing up, from the endocrine perspective, use agents where they don't cause hypoglycemia, they don't cause weight gain, they reduce beta cell stress. Try to look at liver, try to look at safety profile. From the CV standpoint, one has to be very cautious. We have to look at CV outcome trials. We need to have neutral outcomes or positive outcomes. We don't have agents with positive outcomes till date. The CV story is still unfolding. There are caveats for agents with CV like glitazones which may unmask cardiac failure. We do have an indirect signal of hospitalizations of heart failure coming up, but we need to be still cautious. Data in animal data looks very attractive. Outcome data is awaited. From the CKD standpoint, we have seen that here probably gliptins have a clear place which might benefit patients. So if you look at from the patient's perspective, patients need drugs which are effective, easy to use, safe, tolerable and affordable. If you look at from the efficacy standpoint, we need to address drugs which will attack insulin resistance, beta cells, lipid lowering, cardioprotective and probably weight neutral or weight loss. From the physician's perspective, we are looking at patient's health and outcomes, good efficacy, sustained over a period of time, robust glucose control and have non-glycemic pleiotropic benefits apart from safety. Thank you for a patient hearing.